Are you going to here or come up? Yeah, okay, that's fine. All right. So do you mind? Hi, I'm Hetty Lee, and I'm an associate professor in the sociology department here at UW, and I will be chairing this session on racial inequality and women's health. And we're very excited today to have three amazing women and researchers present some of their research in this area. So our first presenter is Wendy Barrington, and she's an assistant professor of psychosocial and community health in the School of Nursing. Our second presenter will be Kemi Dahl, who just arrived here in July. And she is a assistant professor in gynecologic oncology in medicine. And then our third presenter is Amelia Gavin, who is an associate professor in social work. Do I have anything else I need to say about you? Okay, good. We've decided, because I think all of them have PowerPoint presentations, that they'll sit in the audience and then they'll come up. And then at the end, we're going to have a panel. And I just want to I'll remind you guys again, for the Q&A part, to please project, because people in the back can't hear. There's something wrong with these mics, and I don't think we're going to help fix it today. Anyway, so thanks so much. I'm going to be timing you.
Okay, can everybody hear me? Thank you so much for the opportunity to be with you here today. This has been an amazing panel, and I think just the way that it's structured has been great, starting with kind of the more individual level factors that are contributing to what we're seeing in healthcare disparities, now moving into population health and kind of more social processes. So really kind of moving up a level and kind of talking about a larger package in which these other issues in which the panelists discussed previously really play a role. And specifically, I'm going to be talking about evaluating mechanisms of racial disparities in breast cancer survival. And the thing that's pretty cool is you'll see some linkages between methodology that I use with methods that Crystal described previously as well. And also some implications about some of the rates that we see amongst populations that I think has definite origins in what we were talking about, these legacies of distrust with respect to differences in access to care, not just availability, but also diffusion of health information, diffusion of innovations. But first, I think it's very helpful that we start with a common language and really understanding what we mean by disparity. So health differences occur, and it's really just a variation in a health outcome, but it is relabeled as a disparity when that variation is resulting from economic, social, or environmental disadvantage. And so one might ask, well, what are determinants of those sorts of exposures? And here is a pretty popular graphic that has been used to illustrate the different determinants of disease, in this case, premature death. And you can see that we have some environmental factors, social circumstances, environmental exposure, healthcare, notably a very small percentage, and then more individual level factors ranging from genetic, predisposition, and behavioral patterns. But I'd like to offer that all of these factors are socially patterned. And furthermore, there's controversy within social epidemiology with respect to using this sort of model because it doesn't account for interactions between these factors. So really, when you think about it, these factors can actually, the influence of these factors can actually sum beyond 100%, if you will. So I kind of launched right into what I was talking about and didn't really kind of tell you who I am. I'm really a social epidemiologist, and really the focus of my work is to evaluate how social processes influence health outcomes. And so when we're talking about racial disparities, I think it's really also important to define what we mean by race. And I think in the context of health disparities, race really is a socially defined construct. With respect to linking to what Janice was saying, it really used to identify and sort people depending on phenotype. These snap judgments about what people look like. And that has social consequences because there are different groups that are going to be differentially exposed to those determinants of health outcomes because they're not equally distributed across these groups. So this has implications for behaviors, biology, and gene-environment interactions. And so when looking at racial disparities, again, kind of linking back to that previous slide, a lot of these impacts are going to be summing beyond 100%, if you will. So bringing it down to breast cancer specifically, here is a graphic of incidence and mortality in breast cancer by race. And here we see that we have the highest incidence of breast cancer among white women. However, we see that there's the highest mortality experienced among black women. So this really has implications. We could talk about the reasons why white women are experiencing higher rates of breast cancer incidence. And another commentary that I was a part of, we kind of examined this with respect to hormone therapy and the implications of added risk associated with exposure to hormone therapy, and how hormone therapy has primarily been used among white women, and how that diffusion, that health information, if you will, used to treat menopausal symptoms was not translated across different racial groupings, and in this case, it may have implications with respect to conferring additional risk among white women. But that's another story. All things being equal, however, looking at mortality, you would expect to see the mortality among white women to also be the highest, but we do not. So this really has implications for disparities in screening and treatment with respect to breast cancer among African American women. So what do we do about it? How are we going to really undo these social inequities? Is it really feasible that we can undo the social construct of race? Likely not in our lifetimes. But that still does not excuse us from the onus of doing something about it. So as social epidemiology really identifying mechanisms linking race to health disparities in order to actually act, to be able to provide interventions to break those linkages between race and unequal burden of disease. So I'm really been taken up with causal mediation as a method for explicating these relationships. And not to go into the methodologic weeds, but it's a very interesting approach because, you know, when we're making comparisons, we can't, ideally we're making comparisons on something that we can change. So if we're comparing whites to blacks, we're not able to change one's race. So that just doesn't make sense. So using a causal mediation framework allows us to make more appropriate comparisons. So in this case, by identifying a mediator that is associated with race, we can look to see what would happen to risk among one group if that mediator were to change and be similar as experienced in the other group, if that makes sense. So in this case, the predictor being race, the outcome, a health outcome, and a mediator, these other more modifiable factors that are associated. And I would even go on to say that really that link between race and health outcomes is primarily driven by these mediators. Like if we were to break all of these ties, there would really be no association between race and excess disease. So with respect to how we can use it within different settings, within the clinical setting, really identifying interventions on more proximal outcomes to delay or ameliorate the disease. And this is really kind of, I think, speaks more to the buzz around precision medicine. But in the context of public health, going beyond study efficacy to deconstruct how programs achieve results, evaluating the effects of healthy public policy, as well as identifying interventions really in the preventive side to promote population health. And here we're starting to call it precision prevention. So possible mechanisms linking racial disparities and cancer outcomes. And I'm talking about really kind of what we kind of consider at this point, and maybe arguably some of these non-modifiable factors, given the interaction with environment, perhaps they really are modifiable to some degree. But really focusing more on what we are, at this point in time, able to modify behaviors, access to care and treatment, and then all of the other factors that kind of go into those packages, which we talked about before with respect to patient-provider communication, etc. So as an example in some of the work that I'm doing, looking at mechanisms of racial disparities in breast cancer survival, I'm really focusing on what would happen if we were to equalize, if you will, the tumor characteristics between white women and black women. How would that impact survival outcomes? And the reason why I'm focusing on this just as an exercise to show you today is because it really has implications with respect to screening, which we know is different between these groups, as well as treatment, which we also know is different between these groups. And I've been working with the Women's Health Initiative to be able to answer this question. And the Women's Health Initiative, if you're not familiar, I'm assuming most people are, but it's a huge study of postmenopausal women, specifically including clinical trial groups as well as observational cohorts. So it's a very large, nationally representative sample. And of those 161,000, almost 162,000 women, 8,463 white women and 638 black women were diagnosed with invasive breast cancer. And for the purpose of this study, I'm excluding those women who had a history of cancer at baseline, who had a BMI less than normal weight, as that might be an indicator of kind of clinical pre-existing disease processes, or missing comorbid data. So, holy cow. Okay, I'm going really slow. So, essentially follow up through December 15th, 2015. So really want to note that we're looking at time since diagnosis and looking at survival outcomes. So that median time is about 9 years of follow-up. And really just acknowledging here that Women's Health Initiative is, as with most clinical trials, are including participants who are of higher socioeconomic status. So there are questions with respect to how representative this is, but we're still seeing associations among women who have pretty good access to resources, and so just keep that in the back of your mind. So with respect to WHI, we see that there are disparities. This is just adjusted for age and cohort membership, because I want to show you the raw differences between African American and white women, and then we can start kind of looking to see what might be explaining some of those differences. So we see that there's this difference in risk of death overall, but that specifically is being explained by difference in breast cancer deaths and then cardiovascular deaths. And I'm going to be focusing on breast cancer for right now. So for the question then is, does stage at diagnosis, is it primarily responsible for racial disparity in breast cancer survival? And the rationale then is, if we were to equalize screening rates between these two groups, would that eliminate the racial disparity that we're seeing? So these are the methods that I'm using, Cox regression models for hazard ratios. Again, starting at the day of diagnosis, to really be clear that this is a survival analysis, and that we're going to be for our mediation analyses, the stage as mediator, and adjusting for individual level covariates such as socioeconomic status and etc. So again, the mediated effect, we have this total effect, which is the association between race and outcomes. So that's kind of what those graphs, those survival graphs, were showing you. And then we have our mediated effect. So how much is screening accounting for this with this association? And I'm doing a bootstrapped simulation model. So this is a pretty cool method, because you're able to increase your power with respect to sample size. So just cut to the chase, because I'm realizing that I'm limited by time. With respect to risk of death from breast cancer, we see that adjusted for age, education, marital status, insurance, smoking, history of diabetes, the association of race with dying from breast cancer, African American women are 56% more likely to die than white women. Now, with respect to what if we were to equalize or to have white women experience the same level of screening as black women, and this is where the contrast becomes little bit more complicated but appropriate. So we're comparing the exposure being screening, we're comparing that to white women and white women. So white women would experience 20% more death if they were to have the same screening rates as black women. So that's part of what's going on. So breast cancer screening disparities contribute to breast cancer survival specific disparities. Also, I'm not presenting this data here, but with respect to, I gave you a teaser with we're seeing disparities in cardiovascular specific survival. Obesity is associated with that. There's a higher prevalence of obesity among African American women, so that's another point of intervention, equalizing the rates of obesity between these two groups. And so that's where next steps kind of lead to quantify the contribution of obesity to disparities in cardiovascular specific disease survival, and evaluate the role of treatment disparities and breast cancer survival outcomes as well. So that's what my next to-do is. But this is all fine and great, but one thing that I'm also conscious of is implications for disseminating this work. I think it kind of speaks to humility, that we talk about humility in the last panel. Really thinking about what are the effects of communicating these results to the public, and how are we to do that appropriately? Because really, I think in epidemiology, we're not really trained to do that. And so, and the awareness, I think also there's a level of awareness that varies as well. You know, are we unintentionally perpetuating negative stereotypes, especially in this climate that we find ourselves in right now? Does focusing on a disparities model, which is really a deficit model, how does that contribute to what we're doing? And I would argue that the causal mediation analyses might be a way of reframing things that might add some onus to groups to make some change. And then finally, how do community groups feel about these findings? And that's, again, these are questions that I think are very important to consider. And